All right, good afternoon, everyone. I hope you all enjoyed the holiday weekend. My name is Deanna Fenton, Program Manager here at the Alliance, and I'd like to welcome you to today's program, which will highlight strategies for maintaining timely referrals amidst the pandemic. Before we go ahead and get started, I'd just like to briefly review a few housekeeping items with you all. When accessing our webinars, it's highly recommended that you use the Chrome browser to ensure an optimal visual and audio experience. If any of you are already using Chrome and experience any audio issues, we do recommend reconnecting to the webinar using the phone number that was provided in your confirmation email. Should you need any assistance, please feel free to contact a member from the Alliance team. Additionally, throughout the course of today's presentation, all of your audio lines will remain muted. That said, we ask that you take note of the chat feature that's located on the bottom left-hand corner of your screen. This chat will be used to pose your questions to our presenters during the Q&A discussion. So if you have any questions that come up during the course of the webinar, please feel free to submit them at any time. Once the presentation has concluded, we'll go ahead and transition to our Q&A discussion, and our presenters will address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, please note registration is currently open for our next webinar, which will focus on organ donation and disease transmission. You can join us for that on September 22nd at 2 p.m. Eastern. Now, registration is also open for our next Transplant Focus webinar, which will highlight medical marijuana and CBD oil use pre and post-transplant. Be sure to tune in for that on September 24th at 3 p.m. Eastern. Now, for more information on all of our upcoming webinars and to ensure you have the latest information, please visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 CEP-C credit and 1 nursing contact hour. Additionally, a certificate of attendance is also available to those of you who are seeking CEs that may not be offered. Prior to receiving your credits and certificates, you'll be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If any of you are listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's webinar by introducing our moderator, Rachael Gibson, Supervisor of North and West Donation System Specialist at LifeGift. Rachael, it's always a pleasure to have you with us, and at this point, I'll go ahead and turn it over to you to introduce our panel of speakers.
Great, thank you, Deanna. Good afternoon, everyone. We have a great panel lined up for today's webinar, and I'll go ahead and be introducing all of our speakers prior to starting. Our first speaker today is going to be Nicole Russell. Nicole is the Senior In-House Hospital Development Coordinator for Tennessee Donor Services out of Nashville, Tennessee. She has worked in the OPO field for about 10 years now and is the current HD coordinator for Vanderbilt University Medical Center. Prior to her career in the OPO field, Nicole was the Director of Social Services and Social Work, and she also holds a Bachelor's of Arts in Social Work from the University of Kentucky. Thank you, Nicole, for being with us today. Our second speaker will be Ann Willingham. Ann is a Donation System Specialist and Family Care Coordinator for LifeGift out of our Fort Worth, Texas office. Ann has been with LifeGift for just about 2 years now and came to us with a couple-decade history in the OPO and transplant community. We are very lucky to have her. Ann was the previous Director of Kidney Transplant Services at the University of Medical Center in Lubbock, Texas, as well as the previous Executive Director of the Great Plains Lions Eye Bank in Lubbock, Texas. Ann has used her 25 years of donation and transplant experience to help empower hospital teams and develop critical care staff to navigate difficult situations and manage obstacles in the donation process. Thank you, Ann, for being with us. Our third speaker today will be Rachael Sabido, not to be confused with myself, Rachael Gibson. We both have the very same name spelling. Rachael is a BSN, RN, and CNRN. She has been a nurse for over 10 years and has worked at Memorial Hermann TMC since 2014. During her time at Hermann, Rachael's worked as a staff nurse on both the acute care neuro unit and the neuroscience ICU. She became a clinical coordinator in 2019 and has been instrumental in helping guide her unit through the current COVID-19 pandemic, while also expanding her unit's capacity to cope with the surge of recently infected patients. And she also has become the clinical nurse manager for the NSICU. Rachael's passion is for neurocritical care and has had the great honor of taking care of many critically ill neuro patients, as well as donor patients and their families. Thank you, Rachael, for being with us. And last but certainly not least, we welcome Tim Dean, who is my counterpart here at LifeGift as our secondary supervisor of donation systems out of our Houston office. Tim is also an in-house donation system specialist for one of the largest trauma and donor hospitals in our great state of Texas, Memorial Hermann TMC. Tim has spent 15 years in the field of respiratory therapy, critical care transport, and hospital education before making the leap to the OPO world. Tim holds a master's in clinical practice management from Texas Tech University Health Science Center and is currently working on his doctorate of education and organizational development from Northeastern University. Thanks, Tim, for being with us. And with that, Anne, we'll go ahead and start off our presentation. Nicole.
It's me. Thank you, Rachael. I appreciate it. As Rachael said, I'm Nicole. I'm with Tennessee Donor Services, and I'm going to be one of 3 speakers today. I'm going to take about 15 minutes and talk with you guys about timely referrals amidst the pandemic. And as Rachael said, I've been with TDS for 10 years, and I think for most of us, it's a passion of ours, and it's more than just a job. And so in reflection and about the topic, we do have processes in place here at Vanderbilt, and we'll talk about those. But something that I want you to take away from today after we go over this, we'll look at each unit and processes we have in place. But it's something that I learned over time. I think initially when I came into hospital development 10 years ago, I thought, how am I going to impact the nursing staff and the medical staff making timely referrals? That's always on the forefront of our mind as HD, is getting timely referrals. And what I've come to learn, and I hope you guys take away today from what I'm talking about, is really not having us imposing a process on the unit, but going to your unit and becoming a part of your unit and having those conversations to ask, what does end of life look like in your unit? What are the processes you have in place within your unit? And how can we as HD coordinators develop a process within that unit and working with them that's something that they have in place to become part of their end of life process? How can we tailor capturing these timely referrals with processes that work for them within their unit at end of life? And so I want to highlight those processes today with what I talk about with you. So each unit is unique. And so initially I want to talk about what are our referral triggers. This is really the forefront of our education as hospital services. We're looking at making sure the staff knows what is the referral triggers and how to make a timely referral to us. So as Rachael said, I'm assigned to Vanderbilt, and to give you a little bit of a glimpse into that, I look at each unit as a hospital because they really do. Each unit has their own unique needs. They have their own unique processes. They have each unit has a lot of potential within one unit. And so year to date, we've had 515 referrals, 59 individuals donate. We have a 75% conversion rate and a 93% timely referral rate overall for the medical center. So what I educate on is the referral process and clinical triggers for the staff to call and make a referral through a whole host of different outlets. And with that, we have the data. And it really is our driving practice of how I look at the need within that unit and making sure that we're capturing referrals. And I'll show you, you can see that I have a unit that has missed some referrals. And we'll go through each of these, and it really will highlight the need to become part of the process for that unit and what they have in place. So ICU-A, we'll talk about that first. You saw they had 70 referrals, 4 were missed. And what we developed here really kind of fluidly came about. We had a unit medical director come, he started, and always encourage individuals, especially new staff, talking with them within HD to develop a relationship early on with medical team members when they come on board. It's really imperative because it sets the groundwork for your relationship within that unit with individuals. So this unit medical director started, and early on we developed a really great rapport with him, and meeting first on a monthly basis and then bi-monthly after we had established a great relationship. And some months I thought, what am I going to talk to him about? Like, we've not really had a lot go on. Everything's gone great. but really highlighting, something always comes about, and keeping that standing meeting has been imperative to develop that relationship. And there's not been a meeting where we don't have something to talk about. So that really was important. What you see here is a flyer that I developed because a lot of physicians are like, what is a physician champion? What would one do? And it really is being a resource within that unit, someone who is knowledgeable and can do peer-to-peer education. And that has been made all the difference within this unit that we have. So we review cases. We look at things that maybe didn't go so well, gaps, also wins, not just going to them and saying, this didn't go well. We also go and have these meetings and say, wow, we're really knocking it out of the park. We're doing a great job at communication. We're doing a good job working together. So this has been really important in developing that physician champion program within this unit. And from there, we've developed other physician champions because they see the great relationship that we have developed, and it has increased communication and ensuring that we're getting timely referrals. Really within this unit, the attendings do drive the referrals being made to us, and it's what works within this unit. It wouldn't work within all my units. So it works within this unit, and then from there we've been invited to the mortality meetings where we review all mortalities within that ICU, and HD has been invited to sit in on this meeting, and we look at has a referral been made, and if we miss the referral, we look at how can we capture it in the future. So there's that open line of communication, and again, it's within this unit. ICU B. This really is been like the gold standard of processes. It's really is when you think of a process, you think of something that is going to track and ensure that something's on paper, that referrals been made. And this unit has had 70 referrals as well, and they've missed 0 throughout the year. And actually for the past 2 years, we've had 0 missed referrals, something that was developed for this unit. It's something they wanted to incorporate, making sure that they called TDS in a timely manner, and it's something that they have committed themselves to using, and it's captured 100% of our timely referrals made to us within that unit. ICUC. This actually came about when we were meeting with administration, and we saw that hospice referrals were being made from the ED. And this algorithm was put into place for hospice referral. So patients were coming from outside facilities. They saw they knew upon admission that death would be imminent, and so they were consulting hospice. And with all great things that come about, this algorithm was in place for capturing hospice referrals and offering that to families. And they weren't thinking about contacting TDS and contacting their local OPO to ensure that we were getting referrals on patients who met criteria for a referral. So some of these patients are ventilated that they would be offering hospice to. And so that's where we recognize the need to incorporate TDS and making sure that our organ referrals made from the ED. And we've seen an increase in referrals from the emergency department from patients who otherwise were going to be going to hospice, and they're capturing patients that are ventilated and meet criteria for a referral. And we've actually had individuals donate from the ED, able to offer that option. And then once we have consent, we can go up into the ICU at that point and start donor management. So this has been a really great process. Again, something that the hospital saw a need for. I think it's ever evolving and growing, and something that we could become a part of and capture referrals in a timely manner. And then ICUD. I think we all have this unit. And something, these are all phrases that you hear when you go back and you're like, okay, we missed a referral. Tell me, what happened. And we can kind of laugh about it, but it's not, we want to be able to ensure that we're capturing these referrals. And oftentimes, as HD, you may hear a coworker or an organ recovery coordinator say, just they need some education on how to make a referral. And that's not simply the case sometimes. You can do all the education in the world, but things happen. And depending on an individual to capture these referrals and ensure that 100% of the time, it's just proven, as I show you, the previous ICUs, that processes work. no matter how much education we do. If we can incorporate that and provide good education, we can capture these referrals. And so what we're doing is now reporting this information out in our donation advisory committee to upper leadership and going over practices that the other ICUs have in place to offer this within this unit to start ensuring that we can capture referrals and this unit adopting a process that works for them at end of life and making sure that we're capturing all referrals that meet criteria. And just some ancillary opportunities within that have worked. We're incorporating SWAYs. We have the Donation Nurse Champion Committee here that's comprised of nursing staff throughout all the ICUs. And it's really a great time for all of us to come together from respective ICUs and talk about what's going well, the area of needs, and developing educational content, especially when a lot of our work is remote. So we're able to use the nursing staff that are still in the ICUs on a regular basis with their peers and coworkers and getting that educational information out within the unit. Also, we've developed flyers and we posted them within all the ICUs, and then also just Zoom education. So it's been really vital during this time, during the pandemic, and capturing referrals and continuing the mission. So with that, I hope you guys found some of that information beneficial. I am going to introduce Anne, who is going to talk about some of her strategies and initiatives to ensure that callback.
Okay. Thank you, Nicole. That was wonderful. I appreciate your information. And also thank you to the Alliance for this opportunity to speak with you today. In September of last year, I was part of an Alliance webinar where we discussed the iReferral project and how collaboration between hospitals and OPOs can bring success to timely referral rates. I also touched briefly on a callback PDSA project that we did, and at this time I would like to take a deeper dive into the specifics of that project. So even though the iReferral project was completely successful and our timely referral rate at a particular hospital was now 100%, the next issue that we saw on our plate was receiving callbacks with updates on open referrals. And the callbacks I'm talking about were when the family brought up donation or prior to withdrawing vent support or prior to brain death testing, just for instance, on any open referral that we had. With the current pandemic situation, OPOs are being respectful of hospital restrictions and limiting our on-site follow-ups as possible on open referrals. So more than ever, it's critical that we have processes in place for hospital staff to call back in a timely manner. So what our experience was challenges with the callback. So we were in a dilemma. What do we do now? I will say that typically in the past, what we were doing every time we had a missed referral or a missed callback was to have another in-service. Whether that in-service was impromptu in the unit or was it a staff meeting or administrative meeting, we were reminding nurses constantly to call us back, call the OPO back with open referrals anytime there was an update. Another thing that we discussed was, or the things that we were doing was a referral pass sheet. We tried this for a while, and this is not to be confused with the end-of-life timeout sheet that Nicole just talked about. The referral pass sheet was actually just a continuation of paperwork that we used to put in the patient's chart before the electronic medical record. So I don't know if a lot of you remember that, but before EMRs, we would add a pass sheet to the progress notes section of paper charts so that all providers could readily see that this patient had been referred to the OPO. It gave instructions for what to do next, and the phone number of the OPO was highly visible. The problem with the pass sheet was after EMRs came out, they weren't readily visible to all staff because now we're doing all of our documenting in the EMR. pass sheets were not being passed off to the next shift. They were being misplaced on the unit. And I think there was an unprecedented time of paper airplanes from these pass sheets. So what we were seeing was the problem was continuing. Patients who had been referred to the OPO previously were still being followed, or sometimes being extubated without a call back to the OPO. So what happens is the OPO coordinator was caught in a vicious cycle of in-services, meetings, pass sheets, extubations, being tasked with follow-ups on the same processes over and over again. And this was our true definition of insanity. We were doing the same thing over and over again and not seeing any true changes in our practices. So we decided that it was time for a change. It was time for a fresh idea. So what happened next is in our particular case, we had a monthly donation committee meeting at our hospital, and we discussed the issues that we were seeing, that there were being continual missed callbacks. So we designated a specialized task force that worked specifically on alleviating missed callbacks. One thing that we talked about in this special task force meeting was to have another best practice alert for a BPA. And what we talked about was too many BPAs can cause the healthcare team to just become blind to them and not pay attention to them. And a lot of healthcare staff, they were bypassing these BPAs just to get their documenting done and get their job done. So that we decided that that was not going to work. Another problem with having another BPA was that the BPA didn't pop up on the screen until pertinent documentation was completed. And so a lot of times, as you know, families come in and they want to extubate immediately with no warning and no talking to the staff. And so the documentation wasn't getting completed until the patient was already extubated. So we decided that another BPA was just not going to work. What we needed was just a friendly reminder, and it was going to have to be something that was visible to the staff, but not necessarily visible to families. It was going to have to be something that could be transferable from shift to shift, and all involved staff would need to know the meaning of this subtle reminder. So in our task force, we put our thinking caps on, and we decided to come up with something very simple. And we consulted, since this was going to have to do with the ventilator, we wanted to consult infection prevention in the hospital and also the respiratory therapy department and get them involved in the project. We wanted to have something, like I said before, that was visible to the nursing staff, but not something that would alert families. And not knowing this, we did this project in 2018. We wanted it to be timely so it could surpass anything such as a pandemic, and it actually did. So I apologize for this slide ahead of time. This is what we came up with. It was a bright green cable tie that's actually placed on the ventilator circuit, and you can see in this picture, if you look really closely, a small green, bright green cable tie that's right on the front of the ventilator. So when we came up with this project, we started a PDSA. It began, and we collected data throughout the entire year of 2018. So the first 7 months prior to beginning the project, we collected data. We set the process in place, and then we collected our post data to evaluate the success of the project. So the plan was to be, after the initial timely organ referral was made to the OPO, and after an on-site evaluation by the OPO coordinator, if it was deemed that the patient met criteria to follow for potential organ donation, then the bedside nurse or the respiratory therapist would apply the cable tie to the circuit of the vent tubing. And remember, this is only after the on-site evaluation, and we are continuing to follow this patient. The plan continued is the bedside nurse, the respiratory therapist, and the doctors were all educated on what this green cable tie means. And it means to call the OPO back because this is an open referral. If the patient declines neuro status, there's going to be brain death testing, first mention of withdrawal, palliative care consult, any of those things, any updates, call the OPO back. One thing for the OPO staff to absolutely remember is that OPO staff should never touch the ventilator on a referred patient. This is a hospital patient, so the cable ties in our PDSA study, when we did the education, it was clear that the hospital staff is the only ones that will place the cable ties after the OPO on-site evaluating coordinator has seen that this is a potential candidate. So the results of our study were our pre-study we did from January through July of 2018, and we looked at a neuro ICU in a primary stroke center in East Texas. There were 36 total vented referrals from January through July, and during that time period, this was before the study, there were 3 instances of the hospital not calling the OPO back prior to withdrawal event support on a potential candidate. Then in July, at the end of July, we did education in the ICU and with the OPO staff to perform the study, and we collected data post-study from August through December. We had 27 vented referrals during that time period, and using the cable tie indicator project, all potential donor referrals were called in, and there were no missed callbacks. So what we learned from this study is that it works. The collaboration between the hospital and the OPO, and I want to stress, this project must be led by the hospital. You have to have the hospital's ownership of this project. They have to assure that they're collaborating with the infection prevention department, especially during the pandemic, and collaborating with the respiratory therapy department. Everybody has to be on board for this project to work in the hospital. It's a simple, effective tool. It's a visible indicator. It's not obtrusive, and it just alerts the healthcare team that this is a potential donor that we've done a referral on, and to please call back the OPO. And the best thing about this, it's pandemic proof. So thank you at this time. I am going to go ahead and turn this over to Tim and Rachael.
Hello, everybody. This is Rachael Sabido. I'll be speaking first. So I am the new clinical manager for the neuroscience ICU at Memorial Hermann Texas Medical Center. We have a 32-bed neurospecific ICU where we treat a full range of neurologic and neurosurgical conditions. We see the most urgent neurotrauma cases, catastrophic strokes, and hard-to-treat neurological disorders. Our Lifelight program ensures that patients that require specialized neurocare can be brought to the hospital in a timely manner. Our relationship with LifeGift begins during our new employee orientation. The process for referrals is hardwired into our nursing staff, and when possible, we ensure that all nursing staff get a chance to take care of a LifeGift donor patient. When patients arrive to the unit, the charge nurse has already looked up the patient to see what kind of care, procedures this patient might be needing. Usually within the first hour, we know if this patient will likely be a LifeGift referral. And if not, the charge nurses are knowledgeable enough to round often on the patient and the nurse to see if the patient has reached a point where a referral needs to be made. Our nursing staff knows the LifeGift team very well and are comfortable calling them and letting them know when there is a potential donor. I think this relationship that we have with LifeGift ensures that we do make timely referrals and we don't have any missed ones. We also have nurses that are very passionate about donation and will come in and help facilitate DCD candidates, which has been a little bit of trouble for us because the patients have to be taken off the unit, and so they need to go with a nurse, and they also need to take physician, and the OR is a little bit away from our unit. So we actually have nurses that will come in and help with that, which is really helpful because, as you can imagine, making a patient one-to-one sometimes, especially during a pandemic, can be very hard when we have staffing challenges. So even in these uncertain times, our processes have not changed. At the beginning of the pandemic, probably March and April in Texas, we saw a drop in our unit census. Most of our trauma cases were very regular, nothing traumatic, because there was that stay-at-home order and people were probably scared and mostly stayed home. As we moved into May and the weeks after the Memorial Day holiday, we saw a lot of our volumes returning to our pre-COVID numbers, but now most of our patients had COVID-19 as an incidental finding. Again, this didn't change any of our processes, and we still made the referrals when necessary. At the end of June, while our volumes are still very high, most patients on our unit were there strictly due to COVID-related illnesses. Just after the July 4th holiday, we were asked to expand our already big ICU by 8 to 14 beds. We literally had an old Burns ICU one floor above us that we could reach by the stairs, and we had to open that up to accommodate this surge in COVID patients. So we were an 8 to 14 bed dedicated COVID IMU unit. It was literally 3 weeks of it was very rough for the team. We had to staff that unit. Our physicians had to staff that unit. They all did a fantastic job in just jumping in and helping and taking extra shifts to make sure that our patients had the care that they needed. I don't know the numbers for July for most of our referrals because a lot of our cases were COVID related. But last month, for August, we did get back a little bit back to normal. We were able to close that unit, and we made 3 referrals last month. Our processes really haven't changed. The staff is very much aware of how important organ donation is, and they do everything possible to ensure that there is a timely referral. And usually we're so well known with the Life Gift team that they'll reach out to us. They come around and round. They check on us. Tim has been wonderful. We always powwow. And whenever we have an issue, we reach out to one another to try and solve it, whether it's a family issue, whether it's a nursing issue, whether it's a physician issue. We just do our best to facilitate organ donation, and we're very happy to be a part of Life Gift program. Thank you. I'll hand it over to Tim now.
Thank you, Rachel. I'll give you that $20 for that wonderful comment later on today. So those of y'all that are not familiar with Memorial Hermann TMC, just to give you a little background, they had 637 organ referrals last year. They have 13 ICUs that we actively receive referrals from. They have an emergency department that we actively receive referrals from. Last year they had 61 donors, and 38 of those came from neuroscience ICU, where Rachael is the manager. So pretty big deal that we work together, and I've been kind of spread thin over the last 2 years I've been there, and just recently we've started putting more resources into that. We're getting more staff in Memorial Hermann TMC to do some education, build those relationships, and things like that. So I'm going to continue with the timeliness amidst the pandemic. This first slide is actually, there's many reasons I want to be an organ donor if I'm able to, but this is probably the most, the one that I think of the most, that I can be immortal and live forever. So there's that. So the pandemic, what happened? So like Rachael Gibson said at the beginning, 3rd week of March or so, we got the order to work from home. This was very concerning to me because over the last 2 years, we've done so much work at Memorial Hermann, and I'm sure everybody else has at their facilities, that this was very worrisome to me, and I didn't really know kind of what to do at that point. And I was afraid that numbers were going to drop and we were going to lose organ donors and things were not going to go right. Limited visits to hospitals, we just completely stopped going to the hospital for a few months. And then in July, we started going back. We were back maybe 2 to 3 weeks, and then the numbers of COVID started to spike, and our medical director requested that we be pulled back out. And it looks like here in the short, next week or two, we're going to be able to get back in there on a limited basis, but that's going to be good for us as far as continuing to build those relationships. Access to leadership, well, a lot of the leaders at the hospital were working from home unless they were actively working bedside. So it was very hard to get access to some of these leaders to, talk about issues we were having or things like that, especially if they, didn't read their emails every day or were out doing things and things like that, or they shouldn't have been out doing things, but if they were, had other things to do. So family accessibility. So Memorial Hermann there for a while shut down all family access unless the patient was being withdrawn on. So us being able to approach families for donation was a little more difficult. We had to come up with some ways of approaching these families, either over the phone or through Zoom, and we actually had really good outcomes with that. And also out of sight, out of mind. It's just like anything else. If it's not right in front of you, you're not going to think about it. So I rounded Memorial Hermann every day before the pandemic, and that was what really scared me, is if I didn't show up in the unit that day, that referrals were going to be missed, or questions weren't going to be answered, or if somebody was maybe iffy on if they should be called in, that those would be missed. So something that really, really scared me at the very beginning. So then started thinking about this, and I actually talked to Nicole and Rachael about what we were going to do and how we were going to handle this at all our different facilities, and trying to figure out a way to get that information into the hands of the medical team. So some of this we were doing previously, but it was very important that we really took charge and moved forward with this and made sure that we were doing this more than we had been before. So flyers and handouts, making sure those were getting to the hospital. This is just donor management goals and catastrophic brain injury guidelines that we would make sure got into the hands of the staff at the hospital. So being that we weren't allowed to go in the hospital, I would actually call the units and get the charge nurses or the managers to meet me downstairs at the front door of the hospital, and made sure all these things were getting into their hands. We always have clinical trigger cards for the badges. This is what they look like. Oh, sorry, went too fast. This is what they look like. We've always been giving those out. Made sure that the education department, they do orientation, and they're very good about passing these out for us. So just made sure they had a stock of it. Like I said, I just met him at the front door, came down, met me, and I handed him a box of them, and he makes sure everybody gets those onto their badge during orientation. Monthly newsletter. I started doing this about a year ago, and I kind of revamped it just for the pandemic, but this is kind of what I've come up with. Again, this one just has donor management goals on it. But I send this to all the unit managers, and I allow them to send it out to their staff as they feel comfortable with. So sometimes I'll put, what a timely referral is, donor management goals, maybe a story of something that actually happened in the hospital without giving any HIPAA information out. I also put their hospital data on the side. I think if they see that, especially the bedside nurses, they'll want to know, well, where do these numbers come from? And then they'll come up and ask me. So making sure this was really getting out. I do tissue. I did a tissue one month. So lots of great things there. And this was a big one that Nicole and myself had been talking about when this all first started, about doing some virtual rounding. So what we're doing is we're calling the charge nurses in the unit every day and just asking if there's any questions, if there's any potential donors, if they had anything going on that we need to be aware of, just as you would do if you were actually rounding in person, but doing it over the phone. Now, this was a little tricky at first because I found that myself, I am an early riser, and I would call in the first thing in the morning, and definitely not a good time to be calling the units because, they're just getting ready for their day. They're still in the patient's room, things like that. So, but it's been very helpful. I think we've caught some missed referrals or some referrals that would have been untimely if I hadn't called in that morning. And I've actually gotten a lot of questions about processes and things like that by doing the virtual rounding. So yeah, here's a little picture of virtual rounding. That's not me, by the way. Rapid follow-up. So this is a little difficult during the pandemic because, used to with the being in person, it was easy to catch the physician walking down the hall, right after rounds, things like that. Now, trying to do this over the phone became somewhat difficult, but it is doable. Sometimes when you can't reach them over the phone, an email will be a great way to follow up afterwards. Sometimes they get back to you, sometimes they don't. Sometimes you'll need a second follow-up just to make sure you get the information from the physicians on some cases that went well and some cases that did not go so well. I try to follow up with my docs on every single case just because I want to know what's working and what's not working. And during the pandemic, like I said, it's been a little difficult, but we found ways that make it work. Donor council. So we have a donor council once a month at Memorial Hermann. It's a big meeting. Everybody comes together, talks about donation. And when the pandemic hit, this was one of the things that I was a little worrisome about. But we waited a couple of months and then decided it was time to get donor council going again. Met with my donor chair. I said, how are we going to do this? And we decided we were going to do it over Zoom. And Zoom worked out really well. Actually, I had the largest amount of attendance that I had had ever at donor council because it was easy for people to get on from their computer, whether they be at home or at the hospital. And everybody by that time had got so used to doing the Zoom meetings that it worked out really well. Now, earlier I talked about our families not being available to be on site for the donation conversation. We found FaceTime, Zoom, and sometimes over the phone have really worked, and we've had great outcomes with that. So, virtual monthly education campaign. So this is something our HD department decided we were going to do in, I believe it was February or March, right before the pandemic happened. And it just happened to be perfect timing because it was something we have actually been using. So our virtual monthly education campaign was something we gave each member of HD an assignment to come up with either a flyer or some kind of presentation to give to the hospitals on a monthly basis. So we've had virtual presentations and directed flyers. These are just some examples of them. Donor management goals. We sent out a presentation that has voiceover on it and sent it out to all the hospitals. We've done some flyers, referral on-site response, what happens there. And this was one we just did. Rachael Gibson and I just did this one this month. And this was a pretty good idea of talking about ancillary services and how they affect donation. So we give, just what the ancillary service might be, whether it be anesthesia or, diagnostic X-ray, echo, whoever it may be, and a little bit about what they do and how they contribute to donation. This is kind of sometimes missed because, they just are in and out of the room, and there's only a quick interaction with the donor. So we want to make sure that we got out to them and reminded them why they're there and continue to help us with everything that we're doing. So with that, I'm going to go ahead and hand it back over to Rachael Gibson.
Thank you, Tim. Well, I just want that concludes the presentation. Deanna, you want to take it?
Yeah, I'll just jump in very quickly to first and foremost thank all of our panel of speakers for such a fantastic presentation. At this point, we'll go ahead and transition into the Q&A discussion. But before I go ahead and turn it back to Rachael to facilitate that discussion, I'd like to just remind everyone that if you do have any questions for any of our presenters, please be sure to submit them using that chat feature. As a reminder, it's located on the bottom left-hand corner of your screen. Additionally, during the Q&A session, I'll have this poll up. So for those of you who may be participating in a group setting, if you could please just complete this poll to let us know how many people in your group are participating, that would be greatly appreciated. That said, I'll go ahead and turn it back to Rachael for our Q&A discussion. Thank you.
Thanks, Deanna. So I know people probably are going to be typing in some questions. We do have some starter questions that were kind of raised, and so the first one is actually for Anne. What was the response from the hospital care team when families asked about why that little green cable tie or that indicator was placed on the vent?
Thanks, Rachael. That's a great question. Well, first of all, when we did our education with the hospital, we stressed how important it was to apply the indicator when the family's not in the room, be very discreet about it. But if the family did notice a difference, which in our experience, we didn't have that happen because it's so small, but we educated the nurses to talk about processes with the patient, and just like when they need to date the IV to know when to change that out, this is just an indicator of part of their loved one's care in the hospital. If they were pressed on it, then we agreed to go to the nurse manager and then have some more discussion with the OPO.
Awesome, great. Next one, Rachael, Sabido, or Tim. What has been y'all's experience with looking at timely referrals? I know, especially with many of our hospitals opening up their own COVID units and having your nurses having to be in full PPE and PAPRs, how have they been able to handle making the timely referral, or have you set up another sort of system to ensure that that referral is made, maybe not from the bedside nurse, but kind of tagging it to a help all nurse or a charge nurse, or some sort of a process being implemented?
Yeah,
Hi,
I'll start with this one. Oh, go ahead, Rachael. Okay.
From the nursing standpoint, our referral times or process really hasn't changed. Our charge nurses round in the morning with the physicians, so they are very fully aware of which patients are maybe not doing so well or are likely to go towards a referral. They also round again in the evening, and then the night shift charge also rounds. So they're constantly rounding on these patients, and that's one of the questions we ask. Hey, is this patient discharging? Is this patient being transferred out? Is this patient going to be a life gift referral? Is this patient going to the OR? So our charge nurses are very much aware of who's on the unit, and if they need to give an extra hand to that nurse, they will do so to make sure that the referral is made in a timely manner. All right, Tim.
And I'll piggyback on what Rachael was saying. In neuroscience ICU, they're very actively involved in the life gift donors, so they know the processes. As a hospital system, I was a little astounded that the numbers did not drop. The timeliness of referrals did not drop over the pandemic, and I think it's both, the hospital staff being dedicated to donation and us coming up with ideas to make sure those referrals were being called in.
Awesome. So there's a question in the chat. How do you define a timely referral? And I think I can speak to that actually just from an OPO perspective. For us at LifeGift, a timely referral, if you have a patient who meets our clinical triggers, so a ventilated patient, GCS of 5 or less, or a ventilated patient, and there's beginning discussion of end-of-life care or poor prognosis, grave prognosis, that call is to come into our OPO within 60 minutes. And so I know also at Tennessee Donor Services, their clinical triggers are very much the same. So for every OPO, they will set up their clinical triggers, and then it's within that 60-minute window is how we capture as timely versus untimely. So if a referral is made at 68 minutes, unfortunately, it's considered untimely. So the more timely we can get that referral, the sooner the OPO is able to evaluate that patient's suitability and then we can determine kind of the plan from there. So if we have untimely referrals, it kind of just leads us into this downward spiral, unfortunately. Another question that came up to the chat, this one, Anne, will also be for you. How difficult, easy was it to get the hospital staff on board with the green tie process? And were they resistant to the idea initially? If so, what were their objections or any of their concerns?
Well, thank you, Rachael. That's another great question. In our situation, we did not have resistance from the hospital staff because this was a hospital-based project. And like I stressed in my presentation, this has to be a hospital process, not an OPO process. And with that in mind, there was no resistance. There was a lot of questions. When we did the education with the hospital staff, they had a lot of questions of why we're doing this, and we looked at their numbers and their dashboard, and they all wanted to make it better. And so since it was a hospital-based project, then we didn't have that resistance that you might have if you go in as an OPO, this is the OPO's idea.
Okay, great. And then, Tim, another question for you. Do you track the email open rates for the HD flyers? If so, what is it?
No, I don't track them per se. That's actually a great idea. But a lot of the managers do email me back and, give me some response. I even send this stuff to chaplain services because they work so well with us. They've been so helpful in everything we do. And he's very good about getting back to me and asking me questions. But some of the managers will talk to me about them. That's kind of how I guess I've tracked if somebody's actually reading them. But I don't have something in stone that tells me, hey, 45 people have opened this email. So that's a good idea, though. I'm gonna look into that.
Okay, great. And then lastly, more of a comment than a question, but there is some interest in a copy of any of the printed education or flyers that are used and for your vent-type PDSA or education. And then also for Tim or myself, education of the month kind of program that we did. Marjorie, you can actually find that on our Life Gift website. We post all of our education materials under I can find it and I'll have Deanna send it out, but I believe it is the Health Professionals tab. We have all of our voiceover presentations as well as every month our education for the month is posted there. So that way, if for some reason a staff member is unable to get that education for the month via email, we also have the web link that we can send out to them. And if you're able to give out any information on the vent-type PDSA, I think it would be very much appreciated.
Will do.
Okay, great. I'm not seeing any other questions currently. Deanna, do you have any other questions for any of our speakers?
I do not. I will give it another second here to see if any other questions come in from our participants. But just to echo off some of the things that you said, I'd be happy to share any of those resources. So all of you listening in, just keep an eye out for that evaluation email that we send out that includes the details on how to claim your certificates and credits. And we'll be sure to include any of the resources that our speakers are able to share with you all. So we'll be sure to include that in that email, so just keep an eye out for that. But it looks like we have not received any additional questions. So with that, I'll go ahead and conclude our Q&A discussion. And we'll also look to conclude today's presentation. So I'd just like to extend a sincere thanks to all of our speakers, Nicole, Ann, Rachael, S., and Tim. Thank you so much for sparing your time to join us today and for sharing your insights. And additionally, Rachael G., thank you so much for your efforts in helping us to coordinate the discussion itself. To all of our participants, as always, we thank you for your participation, and we look forward to seeing you again in the future. Enjoy the rest of your day, everyone.